Hello. Hi.
Hi.
How are you?
I'm good. How are you?
I'm good. I'm cold. I'm all over.
Where are you located?
Well, right now I'm in Colorado. So, and I love it cold. It's just, I keep the heat down because I like it to be cold at night. And then I wake up in the morning and I'm like, where are you
Time to
at?
put those layers on.
Exactly. Where do you live?
I'm in Arkansas, Northwest Arkansas. So it's actually pretty warm for this time of year. It's, I think it's going to be in the mid 60s today.
Okay.
So it's really cold in the mornings and at night, but it warms up when that sun comes out. So
yeah.
I like it.
Hold on, I'm going to turn this light off back here. It's kind of glary. My brother's in Atlanta and my mom's in Maryland. And actually, even here, the temperature went up because we got snow the other day. And I mean, it's been in the 30s, but now it's going up to like the mid 40s or 50s. But I'm driving back to Portland on Saturday.
Mm-hmm.
So I'll be there for a week for Thanksgiving and then come back here. But I'm going skiing tomorrow. I'm so excited.
Yay. Well, I noticed that you've been having several injuries lately, so I'm glad you get to do that.
No, well, my shoulder. So I self-diagnosed rotator cuff tendonitis because it sounds exactly like the definition. And I actually had a cortisone injection a couple weeks ago. And my dog likes to go under the blankets at night. So like kind of in my sleep, I'm like doing this and trying to lift the covers up and I screwed it up again. So I don't know, skiing might be a little weird, but my snowboard boots are back in Portland. I was planning on going snowboarding tomorrow. I'm like, oh crud, I don't have my boots. So I'll give it a shot in a few hours.
That's right.
I don't think it's going to be like stellar conditions anyway, but just to say I did it, you know?
Exactly. Yeah. Especially since you guys have new snow there. It'll be nice.
Yeah. You know, and they've got all the snowmaking going on and all that good stuff. Do you ski?
I have one time, but I've only been to Colorado once, and I was really young. I had to be like maybe 12.
Oh, okay.
But I loved it, and I was so good at it. So that's why I should have tried water skiing when I was in my prime, but I never did. But I really enjoyed snow skiing.
You know what? I hate water skiing. I mean, it's like snow, hard water, I love, but I don't like being in the water. So I'm like really weird. Okay, I see people are already starting to try to get on. So let's figure this out. I know there's a way, I think, to like make you a host. Let me see if I can figure out how to do this. All right, so more. Let's see. Okay, host only. Participant can chat with. No, that doesn't work. And let me know if you have any idea how this works.
I've been trying to play around with it too. We've got our yoga classes on Zoom, so.
Okay, so I'm going to make you host, and hopefully that doesn't put the onus on you to let everybody in the room. So let's see what happens.
Okay.
Change host. Okay, I have a feeling that did. So I don't know what else to do.
Okay. I've seen it before where it says make co-host, but it's not there.
I'm going to reclaim host. More lock meeting. Ask all meet participants upon entry. Well, we can wait till like everybody's in. I'll let them in. And then, God, the only thing that sucks is once I do that, if people come in late, then we're screwed because I can't let them in because you'll be host.
Do you want me to do that? Is there any rhyme or reason to adding people? Like,
yeah, because they can't watch it and it's stupid the way it's set up. Like I have to let everybody in. But I think here, I'm going to go ahead and let everybody in and they may know what to do because now I'm going to go to a gallery view. Hi, ladies. Good morning. Hannah and I are trying to figure out how to make her front and center for you. If anybody knows how to do this, please do tell, because I want you to be able to focus on Hannah since we're going to be doing the postural assessment on her. Feel free to unmute and.
Oh, Andrea, one thing that I have done is if you spotlight
Okay,
me, it should show me.
Spotlight. Yes. Okay. So do you gals, do you all see Hannah front and center? Is she like the main picture that you guys are seeing? Yeah. Okay. Okay, cool. So we'll wait a couple minutes. We just jumped on early because we wanted to make sure that this worked. Feel free, like I said, if you want to unmute and talk, but I'm going to talk to Hannah about how we're going to do this just so this goes smoothly. All right, so that being said, Hannah, what I usually ask is that the client doesn't have their shoes on, doesn't have their socks on, so that we can see, feet and all the good things. And then I'll have you march in place in front of wherever you're going to stand. You'll see there'll be a lot of kind of moving around, and I'm going to give you a CETI shirt for doing this because I don't know, it's like whoop, whoop. See, there is some benefit, but this will show everybody, it's not the easiest to do virtually, but we absolutely can do it. And I've been doing these since, March or April, right when COVID started, and we started doing all this online training, and it actually works out really well. It's not perfect. We'll do the goniometric measurements next, which I've moved to next week because I can't do it as well showing you guys virtually. I need to have somebody that I can actually do it on to give you a better feel for it. So next week I have my daughter, my husband, I'll be back in Portland, and I can force them to be my victim. So while Hannah's getting all set up, we've got about 2 more minutes. I'll keep letting everybody in.
Hannah, where did you get that spotlight? Where is that?
So if you open the participants, you can go to where it shows more.
Open the
And
participants.
you can spotlight them.
Okay, so open the participants and what?
And then you'll go to the right of your screen where it shows everyone in the group.
Yes.
And then if you hover over someone's name, it will say more.
Actually,
I guess you have to be a co-host to do that. Okay.
So Sally, do you not, in your main screen, do you see me or do you see?
Oh, no, I see her fine. I just wanted to know how to do it, so I know how to do it.
Perfect. Yeah, there was something and I just hovered over her, and I think that it was the drop down menu, which now I think it's not working because I've already made her. It says spotlight video, and so that's what I did.
I think you have to be co-host to have access to that.
Maybe. I mean,
That's okay.
Even after doing this for the last 8 or 9 months, I'm still technologically challenged. So that's what Sally, when you ask me things, Sally, I'm just like, oh God, I'm the wrong person to ask. So hopefully Greg's been helping you out.
Yes, thank you.
Hopefully everybody's figuring out, how to access the videos and whatnot. And although we're coming to the end this week, next week, I will, and I'm sure Dan will also add some extra sessions, give you some time to kind of get through this, and then we can do some study sessions. And I'm certainly willing to do them anytime, but I think it may be better if we give you guys a couple weeks, we get the holidays and everything. And I'll kind of take a poll and see if you'd rather do it sooner rather than later. The brand of goniometer, Vernet, this one, I've never even heard of it, but I bought it apparently. This is called Ever Ready First Aid. Now we're not doing goniometers today in case anybody missed the message, because I had to switch things up due to not having anybody to do it on. Baseline is another good one. Honestly, I think the best way to determine, and this is kind of sad, whether it's decent or not is the price. It's the old, you get what you pay for. So if you're paying $2 for it, it's probably not going to be great. the average price, $10, $15 for a 12-inch one. And the reason why, whoops, I'm gonna keep letting people in here. You want one that's sturdy enough that this movement arm will actually hold itself in space, because what happens, and eventually if you use it enough, you're gonna need to replace it. The axis just grinds down, and then the movement arm will start spinning around. And you'll see when we actually do goniometric measurements what I'm talking about, because it makes it really complicated. So, okay, ladies and gentlemen, maybe all ladies so far, we have our beautiful volunteer, Hannah, I'm pronouncing it right? It's Hannah?
Yes, yes.
Okay, sometimes it's Hannah, so just, you know.
Hannah is correct.
She's volunteered to be our assessment person. So what I want to convey to you all is that this is not perfect when we're doing this virtually. You can probably see in my screen, you've got this beam of light flooding in. And of course, you know, Hannah's going to have her things in her room, depending on light coming in. So we try and modify things as much as possible. And yeah, Hannah, I don't know, we may decide that we want more light. So this is the thing, it's a lot of back and forth. And what I try and suggest to people, so if you're working with a client, you may suggest or request that they have somebody there when you're doing the assessments, that can actually help you out. You know, maybe it's moving the computer screen, you know, so you get them better centered in the camera. Maybe it's changing the lighting, opening a window. It could even be, you know, pointing to a part on the body that you're trying to take a measurement of. So this is kind of a group effort. But nonetheless, I think that we can absolutely gather enough information from a virtual postural assessment to absolutely make it worth our while. Now, without putting anyone on the spot, I'll just put this as a rhetorical question. You know, how many of you have used postural assessments in your practice? Now, if you're a group exercise instructor or yoga instructor, which typically is in group format, you probably have not, because you don't have the opportunity to meet one-on-one with people. And so what I am going to suggest to you who, well, actually, I guess do me a favor in the chat box, make this real simple. If anybody does teach group exercise, shoot me a chat, just say yes. And then that'll give me a better idea also how much more time, you know, I'll spend with you guys on that. But even when we're creating a group class for cancer patients, it's really important to narrow down our class participants, because cancer is too broad. You know, there's a spectrum of ages, there's a spectrum of fitness levels. Thanks, guys. Thanks for shooting me these messages. There's all different variables. So we want to try and make it as easy as possible and start with a small group. We also want to choose a finite number of, you know, days or weeks or months for the class. So it's not going to be your drop in, like you go to the YMCA and, oh, there's a Zumba class. Great. I'm going to go do Zumba. We're starting November 1st. We're ending January 1st. We'll allow 10 participants into the class. And the same people start are the same people that finish. You don't let anybody in as you're going along. This makes it much more beneficial for the participants as well as the instructor, because your attention isn't any more divided than it, you know, already would be in a group class. Because imagine how complicated it is. Let's just say you've got 10 breast cancer patients in there. And then somebody else comes in midway through the, you know, the 12-week session, and you've got to explain everything to them and get them caught up with everyone else. It's a real distraction for everyone in the class. So if you're teaching group classes, I suggest a beginning and an end point, and try and narrow down your audience by type of cancer or upper lower body or age groups or in treatment, out of treatment. And we can talk about that in more detail. But the reason I even brought up group exercise is typically assessments are not done. You know, they sign the liability release when they join the gym, the club, the studio, and that's it. Hold on, I'm going to turn off my, put this on airplane mode so we won't get cut off here. you know, so there's no other interaction other than they walk in the club and they go to class. So if you can incorporate a postural assessment, if you do nothing more than a postural assessment and maybe a quick range of motion test, what it enables us to do is, you know, kind of dial into each individual's needs, even in a class setting. And they do this at Fit Body Boot Camp. They have all these different color, you know, the rubber wristbands, red, yellow, orange, pink, green, blue. And you can designate with each color, let's say upper extremity lymphedema or lower extremity lymphedema or limited flexion, limited extension. So you can kind of color categorize each postural deviation or range of motion limitation, so that when you're teaching a class, everybody's already got their bands and you can say, okay, everybody with a red band, when I do this, you're going to do this. I'm just making up an example, but it's a great way to make a group setting more individual, because the ultimate goal is to individualize exercise program for each and every cancer patient, since they will all have different responses to treatment, different outcomes, so on and so forth. So the postural assessment is hands down, I feel, the best tool for any fitness professional. And believe me, there were years that I was not doing it. No one ever taught me. I had no idea. So you will be able to take this information and apply this to any of your clients. They can be, you know, youth athletics, they could be seniors, they can be anywhere in the middle, they could be pregnancy clients. It will help you to really narrow down what they need specifically, not just some generic, you know, chest, back, shoulders, biceps, triceps kind of workout. Okay, so that being said, Hannah, we're going to get you started. We'll have you stand up wherever, I guess, in front of the, what do you call them, curtains. Now, most clients are not going to want to be in their skivvies. So I know usually I have my husband doing this and people are like, well, he take off his shirt, and he's like, no, you know, so the majority of your clients are not going to want to be in their sports bras or their spandex. Some people are cool with it, others are not. I leave it up to that individual. I can make a suggestion, but obviously it's up to them. We do want them to wear, you know, loose enough fitting clothing so that they can move. If somebody's wearing jeans, it's going to be very restrictive. And we always want them to take their shoes off, because if they have lifts or orthotics in their shoes, we're not going to be able to see what's going on with their feet, and it can change their movement and everything else. So as you all see, I assume we're seeing the same thing on the screen. We can see Hannah from mid-thigh up. Now, to do a postural assessment, we need to look at the entire body. But we're going to have, don't worry, Hannah, we're going to have to do this in bits and pieces, because in order to get all of you in the screen, you're going to look this big to us, and it will be very difficult to see the details. So what this means to our clients, as we describe this to them, is, you know, we're going to have to stop, and I will have you march in place again. And then I'll have you go to different angles. We're going to do the front, we're going to do each side, and we're going to do the back. And this is why, if they do have somebody there, then that person can be adjusting the camera or the computer, as opposed to, you know, right now, Hannah, it's you, yourself, and you. So you're the one that's going to have to move everything around. I always tell people to march in place and stand naturally. And this will be a question on your test. And it is I believe we're in module 3 now, going through the assessments. So what we don't want is for somebody to stand up perfectly straight like this, unless that's their natural stance. People are always wanting to, you know, impress and stand properly. The idea of marching in place, it's an option compared to any other dynamic movement, assuming we don't have room to watch you walk down the hall and that type of thing. And it allows people to just not think so intently about how their stance is going to be. So if anybody has any questions, shoot me you know, something in the Q&A, or go ahead and unmute, and we'll see if that gets too distracting. You know, we'll go back to just putting it in the chat box. All right, so Hannah, we are going to have you march in place for just a couple seconds, stand naturally with your arms by your side. And I do suggest that people close their eyes. if you have a client who has balance issues or they're afraid, then don't worry about it. You know, just have them march in place with their eyes open. And if they need to have a chair there in case they're worried about falling, that's okay too. So let's go ahead and do that. And just, you know, a couple times, and then just let your arms fall how they will. And I want you to hold that. So the goal right now is for you to stay as still as possible. Now, I could make a suggestion in advance to Hannah and say, you know, go ahead and pull your hair up, you know, if you have a ponytail. There are certainly things that could make this easier, but I'm going with whatever we have here because that's how it's going to be with you and your clients. So we want to start off, if you can imagine, a plumb line right down the middle of her body. Everything should line up from the top of her head to the, you know, the middle of her nose, the middle of her chin to her sternum, down to her pubis, straight down the torso. So just kind of take a look yourself. We're doing this together. And, you know, if you notice anything that is very obvious as far as asymmetry, go ahead and, you know, speak up or put it in the chat box. Personally, from where we stand right now, everything looks quite symmetrical. I can envision a line just going right down her body and everything, you know, basically looking even in terms of the distance from the midline to the lateral portion of her torso. Okay, that's about as detailed as we are so far. So now I want to look, and Hannah, is it possible to just move your hair? Oh, you have a ponytail? Yay. Okay, awesome. And then we'll just, you know, have you drop your arms again and just shake it out. Okay, so now what we want to do, let's look at her earlobes. Do they look level? They seem pretty level to me. If I were to take, and you can even do this right up against your computer screen, you can take a pen or a ruler, pencil, and literally, you know, hold it up to the computer screen where your client is at. Now we just lost a lot of light, Hannah. I don't know what happened if a cloud rolled over. So I guess we'll do the best we can. This is real life. Hold on a sec. All right, there you go. Okay, so ears look level. Next, I'm going to the shoulders. We want to see if the shoulders are level or if one shoulder is higher than the other, and kind of simultaneously let your eyes go to her hands as well, because oftentimes if a shoulder is elevated, you will see the opposing hand seem to be lower because it's contralateral. Okay, so does anybody notice any difference in her shoulders? Kim is saying right shoulder a bit lower. That would be my guess too. Very, very slight. And we also have to ask ourselves as we're doing this, you know, if we're picking things apart, how important is it? Hold on, guys. I'm gonna get a paper so I can write these down. Okay, and then I'm a big paper and pencil kind of person, so I'm just going to go right shoulder, and then I just, you know, put an arrow slightly lower. Now the cool thing is in the back of your module 4 and also in your teachable platform after you finish all 4 modules, you actually have the forms, so you can print it out, and there is an assessment form, and all you have to do is it'll say rounded shoulders, yes or no, slight, moderate, severe, and then it'll break it into left and right. And so, you know, you don't have to do like this with the paper. Okay, now Stacy is already moving forward, which is awesome. Right shoulder is more internally rotated. Stacy, do you want to unmute and go ahead and share? Because, you know, I can say this all day long, but let's tell everybody why you are saying the right shoulder is more internally rotated or protracted.
Okay, so I'm looking at her hands, and you can see the back more of the like the pinky side of her hand on her right side than you can on your left side. So. Yes.
So
should I just stop there? Yeah.
No, hold on. I'm going to exaggerate even more. So if somebody had, let's just call it perfect anatomical posture, their palms are facing their body. And if they're like, a big bodybuilder and they have really upper crust syndrome, their palms are going to be facing totally backwards. So Stacy's spot on with that being an indicator of protracted shoulders. So yeah, go ahead if you have any more comments on that, Stacy, but that's right on.
That's actually what I was looking at. And I thought maybe perhaps that's why we're seeing the shoulder being lower, is because it's a little more internally rotated. So I just kind of went from one to the other. So
yeah, absolutely. So not only am I writing, right shoulder lower, I'm going right shoulder slightly protracted. And it's all up to you, slight, moderate, severe, whatever you determine is appropriate for that person. Now, just out of curiosity, Hannah, do you have any injuries or anything that we should be notified about? Okay, and are you right-handed or left-handed? Okay.
And I sleep on my right side.
Okay, and all of these things can play into it, from what side you carry your purse, your briefcase, holding your phone, all of those day-to-day activities. Okay, anybody else see anything that is notable, upper body? Now, of course, we only have one view right now from the front, so we can only see certain things. Go ahead and straighten your fingers out if you can for a sec. Okay, so if you look, her right hand is probably like an inch, it appears to be an inch lower. And that is probably because that either the left shoulder is elevated or the right shoulder is depressed. We're not sure yet. This is all part of the process here. Okay, you can relax. All right, the next part is a little bit challenging because most people don't know their own anatomy. So we've got a couple of terms. We've got the iliac crest, which is the crest of your hips. If you're to go like this, it's those top bones. Then you have your anterior superior iliac spine, and then the bony parts on the back, the posterior superior iliac spine. So the ASIS or PSIS. If you talk to your clients like that, they're going to look at you like a deer in headlights. They don't have a clue. So what we're going to do is cue them for where to feel. And this is where having somebody else there can be very beneficial as well. So right now, what I want you to try and do, Hannah, is using your fingers, keeping them just, horizontal like this. Maybe your second finger's better. Go ahead and point to the top of your iliac crest. So what we're looking for is, are the hips level? So here, let me show you. I have so little room in here to move around. Okay, so here, me derobe. All right, so if I were the client, I would be going like this. So I'm poking at the top of my hips, and then it's for you all to take a look and see, do her fingers look level? So all your fingers are in the way, and this is okay. This is all the learning curve that can you do this with your fingers?
Like forward?
Look at my fingers. Oh yeah, it's probably just like this, like yes, there you go. Okay, but right at the top. So we want to see them. You're pointing to your ASIS. I want the top of your hips.
Oh.
That's what we're looking for. Perfect. Okay, so best you can you guys tell, do they appear level? I mean, if they're not level, it's minuscule, because if I were to take my pencil and go from finger to finger, just right there on my computer screen, it's level. My pencil's not dipping one way or the other. Okay, perfect. Now I want you to find the ASIS. So specifically what we're looking for now, folks, is rotated hips from this front view. So go back to that plumb line, draw a big red line down the center of her torso. And are her ASIS equally spaced from that plumb line? And I'm going to let you think about that for a couple seconds. And if anybody wants to share any input, feel free. Sorry, Hannah, you get to just stand there and look pretty. Okay, so take that plumb line right down the middle And are her fingers equally spaced from the center? Now, I personally see a little rotation inward on the left side. So if you were to draw a plumb line down the middle, that it's very slight. That left finger, that would be teeny bit closer to that midline than her right finger. So I'm just going to make a note, very slight medial rotation left hip. Okay, you can relax your fingers. All right, so from where we're at right now, there's not much more that I can see, you know, all things being equal with lighting and what have you. So now, Hannah, we're gonna drop the screen down, and I'll need you to march in place again, just so we are as natural as possible. So just oh, that's great, yeah. And preferably, if you can have your clients wear shorts or pants that they can roll up over their knees. Can you get that left side up a little bit more? Because we are going to want to see the patella. Perfect. And you know, you got to be a trooper to volunteer to do this. So big kudos and thank you to Hannah. All right, go ahead, take a couple steps, march in place. And then just, you know, land where you will and relax. All right, so what we are looking for now, we are looking at the knees and we are looking at the feet. And I probably don't have any better of a view than you all. So I will say to you, you know, it is a bit fuzzy. The lighting isn't fabulous. And Hannah, this is no insult to you. This is how it's going to be with probably every client you do this with, unless they're in, you know, a studio that's perfectly well lit. So let's try, in the absence of anything better as far as lighting, let's look at her patella. Let's look at her kneecaps. I can see the right one better than the left, probably because it's closer to the light, but do they appear level? Do they appear centered? Or do you detect any rotation sideways, which would be more bow-legged, or medially, which would be more knock-kneed? Anybody see anything that jumps out at you? Vernette, if you're talking, go ahead and unmute because I can't hear you. I see your mouth moving. Maybe you were just talking to yourself. Okay. All right. So, go ahead. Somebody talking or just clearing your throat? Kim is saying the left knee, so let's make sure we're looking at the proper side, is slightly medially rotated. And that would be my interpretation too. However, it's really hard to tell because of the lighting. So Hannah, just for kicks and giggles, is there any way to get more light on your lower body, either through moving the, opening up the drapes or like putting a lamp more on the floor?
Yeah, let me try a couple of things.
Okay, cool. All right. So, all right, guys, so stay tuned. Oh, that looks better, I think. Okay, and then if you could just hike your left pants up just a smidge more. The white curtains in the back are perfect because then we
Yeah, I
don't
think they help.
any distractions. Okay, I think that's better, don't you all? All right, so let's look at those knees again. Now, I actually think both of them are slightly medially rotated. Slightly. And, you know, one of the things about the postural assessment is it doesn't always tell you everything in and of itself. A lot of it we have to see by doing the squat test, doing the modified Thomas test, which helps to just reinforce our findings on the postural assessment. Okay, so let's just go with slight medial rotation of the knees. That's my opinion. And then let's look at her feet. Now remember, this is only one angle. We have 3 more to go. Slight medial rotation knees. Anybody?
Andrea, could Hannah just take a step forward once?
Sure.
Just
And
get a
you guys
little closer to the
feel
feet.
free to speak straight out to Hannah too. Yeah.
Okay.
Yeah.
Thank you.
Absolutely. All right. So we are looking obviously to see if the feet are straight or if they're slightly turned out. And so Anne is saying right foot very, very slightly turned outward. I mean, teeny tiny, but let's make a note of that. What about pronation supination? Can we tell anything from here? I mean, I personally might see a little bit of pronation rolling inward on the left foot, but it's really, really hard to tell from this angle. Anybody else see anything?
The left side leg is quite large. The muscle is protruded.
Hypertrophy? Is that what you're referring to, the size of the leg? Or
Yeah, the lower.
Well, the one thing that I did notice, and I don't know if you're seeing this, is it looks like the left thigh might be a little more developed than the right thigh.
Yes.
I'm looking above the patella. Okay, and again, these things, it's hard to say because lighting can do a whole lot. I mean, look what it does for models. So, all right, anything else that we can see from the front? Anybody have any input? And if you don't, that's fine too. We keep going. Okay, so let's keep the camera where you're at, Hannah, but if you will face your curtains now and march in place again, just to kind of reset, if you will, and then just stop whenever you're ready. Okay, so now let's start at the feet. Let me have you take a couple more marches because you're kind of cattywampus, and maybe that's how you stand and maybe it's not. Okay, that's better. All right, so now let's look at the feet. Okay, so when she was facing us, we said the right foot was slightly turned out. Now you can see it even more, right? Because now it looks, actually, the left foot looks more turned out now, and the right foot looks straighter ahead. Do you guys see that? Okay, and I also, personally, I see pronation. I see rolling inward, particularly on that left side, which I think I also saw in the front. So yeah, we agree, Anne. The right foot is kind of hard to tell. I mean, I sort of want to go with pronation. Now, typically with both feet being pronated, we would also see a bit of knock knees, which if she has it, it is not obvious. But also she doesn't seem to be excessively pronated. Okay, here, hold on.
Is it possible that doing like a calf raise a couple of times can show us how her gait would be?
We can absolutely. So right now, so hold that thought and then, yeah, go ahead. And we can have her walk forward. I mean, obviously we don't have a whole lot of room, but do you want to try and just take I don't know how much room you have there, Hannah, if you can take a couple steps or back up a little bit more and then walk forward. All right, let's try now.
And knowing that everyone's watching.
Yeah, exactly. Yeah, it's hard to say because we're only getting like 3 steps out of her.
I'd exchange your feet and ankles for mine any day, Hannah.
Thank you.
You know, and I'm also looking at the Achilles tendons. So when I look at her left and her right foot, the left Achilles is more vertical, where the right one is slightly turned out. There's definitely something going on at that right foot ankle complex, and I can't quite make it out because it almost looks like a combination of a little bit of bowing out in the lower leg, and you know, you see that kind of outward curvature, but then it still looks somewhat like she's pronating. Usually when somebody's bow-legged, and you're not bow-legged, Hannah, I'm just making a statement, oftentimes their feet are supinating, so they're rolling on the outside of their feet. Where if somebody's more knock-kneed, they tend to roll on the inside of their feet. So
Can I say something? Is this Kim?
Sure. Yeah.
I noticed right away what we're talking about with Hannah right now, because I have on my right leg, but it's just a little more obvious for me. And I always wondered if it was a leg length discrepancy and how the bones or joints and shape of the leg has accommodated for that.
And in your book, you'll see, I believe, you know, I'm saying this and then I'm like, wait a minute, did we take that out? I think it still talks about leg length discrepancies and how to measure it from the medial malleolus to the anterior superior iliac spine. But the thing is, and what I've been told is that without actually doing an x-ray, there's no way to truly determine if there's a leg length discrepancy. And also, usually when there's a leg length discrepancy, we would see one hip higher than the other. So it could either be tight quadratus lumborum on the back, lower back area, or it could be a leg length discrepancy. So I don't think any of us are perfectly symmetrical, but if Hannah has one, it's certainly not obvious. All right, let me read a couple of these statements. So Stacy's saying from the back, the knee looks like it is rotated inward. Are you referring to the right knee, Stacy? And then Miriam is saying it looks like her right femur. So everybody's saying the same thing, like the right knee is medially rotated and head of the femur can be factor. So yeah, there's a lot of things that can factor into this, and know that you can do a very intense assessment, more so in person than you can virtually. And sometimes we're just trying to gather enough information to do the best we can with what we have, even though we know that we could, get a better result in person and spending an hour doing all this stuff. So, okay, anything else before we have her turn sideways? Okay.
Would you address the arches? Can we ask Hannah if she knows if she has flat
You
or high
absolutely
or medium?
can. You absolutely can.
So
So
not aware.
So Hannah, do you know what your arches are like?
I do not.
Okay.
I mean, they're not flat. And I've been in athletics my whole life, so I'd say they're pretty arched, but I don't know anything more than that.
yeah, and hopefully we'll see more from the side. Another thing that I sometimes see from the back, when the back leg is kind of flattened out, if you will, and there's no softness in that, what do you call it, the crease of the knee, it can be hyperextension because the quads are tight, so it's pulling, if you will, the hamstrings. Because as what happens when the front shortens, when the quadriceps shorten because they're tight, it stretches out, it extends posteriorly in the hamstring. So kind of hard to tell, again, because of the lighting, but we will also be able to look from the side and reaffirm or deny that. So go ahead, Hannah, and just pick a side, either side. We're gonna always go back to the marching in place and just a couple little steps. And your clients who are not very fit or active, they can just take little steps. It doesn't have to be anything spectacular. So let's, again, start at the ankle, look at the knee, look to see if you notice any hyperextension, if you notice just anything that jumps out at you that perhaps you did not notice from the front or from the back. Her feet still maintain their almost perfectly straightforward positioning, just slightly turned out. I don't see anything that's super obvious that would indicate to me that her legs are hyperextended. Oftentimes it would almost bow out, if you will, behind the knee when they're hyperextended. Anybody else see anything from this angle? And here's the thing, if we're like literally looking through a microscope, it's probably not that significant. Okay. Rather than have Hannah adjust the camera, let me go ahead and have you face the other side, Hannah, and then we'll do everything top of the body. So again, march in place a couple times and then just relax. Okay. All right. Now, it's I think we see a little bit of her left calf peeking out behind her right calf. So it gives the illusion that her leg is bigger than it actually is. And it can actually look like it's kind of arced in the back, but I believe that that's her left leg that we're seeing. There you go. We've got like this much of the left leg in there. Again, I don't see anything that leads me to buy into the fact that she's terribly asymmetric. Everything looks pretty well aligned. I'm always drawn back to the feet. Let's do this. Let me have you just move your right foot back so we can look at the arch. You can go up on your toes or whatever. Okay. like just, no, like just get your right foot back. There you go. Perfect. Okay. So she's got what I would call a normal arch. She certainly isn't flat foot. From this angle, it does not look like she is pronating, that she is collapsing in. You know, I think that in real life, if we were, you can relax, Hannah, we might see a little bit more, but from what I can tell through this process, virtually nothing jumps out at me. I would be asking questions, you know, about people's daily habits. And, you know, Hannah, we can go ahead and shift upward now, if you don't mind. You know, absolutely things like, you know, what hand do you use? Do you carry your purse? Do you carry your phone? You know, are you sitting at a desk all day? Because all of these things can help us to determine perhaps, you know, what some of these imbalances are resulting from. Can we lower the screen a little bit so we get more of you? Perfect. Okay, now we've already seen the top half from the front, so we're gonna spin you around to the back. All right, once again, just kind of marching in place. Now, if we just had somebody in their sports bra, obviously we would see more as far as the scapula. I mean, we're really guessing here unless we have somebody there with them, or yeah, doing that helped too. I can see a little more pronounced left scapula than right. So once again, I'm looking at the ears. They look level. I'm looking at the shoulders. You know, we see that depressed right shoulder. That hasn't changed. In fact, I think it's even more obvious from the back. And then I want you to imagine that plumb line again, going right down her spine. So if she had somebody in the room with her, I would have them actually go and palpate her scapula and trying to find, you know, the medial border so that we could see how far each shoulder blade is from the spine. You know, is one further rotated than the other? I can't tell that right now. It's impossible unless you have x-ray vision, okay? But Hannah, what I'm going to ask you to do, if you can kind of pull your shirt toward the front so it's a little more fitted in the back. All right. Now, do you see her, sorry, but a little bit of winging on particularly that left shoulder blade? Do you see how it pops out just a smidge more than on the right side? Everybody following me? Okay.
Yes.
And if somebody had an axillary lymph node dissection, one of the potential, and yes, Kim, it could absolutely be a shadow. One of the side effects of the axillary lymph node dissection is winged scapula. When there is damage to the long thoracic nerve, it can result in a ceasefire of the serratus anterior, and then kind of the opposing muscle, the rhomboids, tighten up. So what's the worst case scenario? I determine, I write down that Hannah has slightly winged scapula. And so that means I am going to have her do exercises to strengthen her serratus and stretch her rhomboids and her pecs. So what's the worst thing that happens if I'm wrong? She strengthens her serratus and she stretches her rhomboids and her pecs. We're not going to hurt her. There's nothing negative that can come from this. You know, if we are unsure or we're right on the cusp of, you know, whether or not we're seeing what we're seeing, you know, these are exercises that are basic for function anyway. We want to, when you think of the pec in the front, the lat in the back, and kind of the serratus in the middle, that's really important for scapular stabilization. And when you think of all the breast cancer surgeries or head and neck surgeries, a lot of people will have really pronounced winged scapula. So what you will then be able to do is flip through your book and you're going to look up the muscle imbalance, winged scapula, and it's going to show you which muscles are tight, which muscles are weak, and it's even going to give you ideas for exercises that you can do to correct them. You can use the exercises that are in the book, or say, hey, I'm a Pilates instructor. This looks like a barrel hug. Or I'm a yoga instructor. This looks like cactus arms. and you can choose your own exercises as long as the goal is, in this particular case, to strengthen the serratus and stretch the rhomboids and the pecs. Everybody follow? And it'll help you as you become more familiar with the materials, and you know, you're like, oh yeah, I remember chapter or module 3, here's the chart for the muscle imbalances, and then the next couple pages show you the exercises. Many of you may not have even opened that module yet, so it may not be familiar to you. Okay, so Hannah, if you don't mind, now again, we're going to have you poke at the top of your hips, just so we can see if it looks level. And for all intents and purposes, if I take that pencil and go from finger to finger, it is level. I could put a water glass on top of it and it's not going to tip over. If we were to see one side higher than the other, you can relax, Hannah. It could indicate a tight, I just totally blanked, QL, quadratus lumborum, which is back there next to the erectors, and is often from sitting and improper posture, can be very tight and shortened, cause a lot of low back pain. It can also be weak rectus abdominis muscles. So remember, it's not always like I could say to Hannah, oh, you have, and Hannah, this is not the case. I'm making this up. I could say you've got tight QLs. Oh, you have weak abs. That's not necessarily true. She could have a tighter quadratus muscle and weaker abs. It's all about balance. You know, it's not that somebody is all of one and none of the other. It's finding that balance and making everything in the front equal with that in the back, balancing out the agonists and antagonists. I do want you, if you don't mind, let's spin to the side again, because I forgot to do this when you were standing sideways. Now, this is going to be a little bit hard because I need you to have one finger in the back trying to poke at your posterior superior iliac spine and one in the front poking at your anterior superior iliac spine. Oh, you're good at this. Okay, now I think that this is just my guess, but I think that your left finger is on the iliac crest and not your posterior superior.
Oh,
Yes, thank you. I was like, because you don't look like you have that big of a tilt. All right, now her shirt is bunched up, so you guys have to, you know, use your imagination a little bit. But I see there you go, an anterior tilt. Notice how her front finger is probably an inch or two lower than the back finger. And you can see a very slight protrusion of the belly because you've got the curve in the low back that's pushing belly forward. So let's do this, Hannah. Think about pulling your belly button towards your spine. See what happens there? So go back to the tilt. Show, okay? Very slight, but look what happens when she neutralizes her pelvis. So ideally, that's where we want it to be. We want to be able to make a straight line from the ASIS to the PSIS. Okay, does everybody see this? Because this is a big one, especially when we're dealing with breast reconstruction, abdominal trams. We're going to see a lot of people with far worse than what Hannah has, severe anterior tilt. You can relax your arms if you're getting tired there. Now, another thing you can do is sometimes you can just look at somebody's pants or, you know, their waistline. Here, I'll try and, I don't know how good my lighting is here. I have a pretty significant anterior tilt. So if you just look at my waistline, and I can barely see the screen, so I can't tell. This is neutral pelvis. This is normal. So see? All right, and it's gotten better because I've done exercises to fix it because it leads to low back pain otherwise. Yes, indeed. So who is SM5251? I don't know who I'm talking to. SM5251.
I hope it's a real person. Okay.
Sheila, okay, cool. So yes, you're spot on. I mean, I think women tend to have an anterior tilt, whether it be from childbearing or God only knows. I mean, just the way we are predisposed. But think about this and what that can potentially do as far as low back pain. So oftentimes, you know, you've got weaker abdominal muscles and tighter low back. We have weaker glutes, tighter hip flexors. So the person who sits at a desk all day long may very well present with this, what we call an anterior pelvic tilt. And so this is the interesting thing. It could be tight lower back, weak abs. It can be weak glutes, tight hip flexors. So we can't tell everything from this postural assessment. We've got to use the modified Thomas test also. And I have a new video for the modified Thomas test that, let's see, I will send you guys the link for. So I'll send out another email when we're done. So you can take a look at doing the modified Thomas test, because we are not going to get everything from this postural assessment. But once again, if I'm wrong and I make a guess that you have tight hip flexors and weaker glutes, so I have you stretching your hip flexors, I have you doing hip extension to strengthen your glutes, and in 8 weeks, if you still have this slight anterior tilt, then I go back and say, okay, well, that didn't work. So maybe we need to focus on strengthening the abs and stretching the lower back. You know, we can manipulate these things as fitness professionals for the purposes of what we're doing. We're pretty much hands off. I mean, yes, in person, we can do assisted stretching and what have you. But when you are working with a cancer patient, we have to respect the boundary between being a physical or physiotherapist, occupational therapist, nurse, you know, someone in the medical profession, versus being in the fitness end of things. We should not be touching, we should not be kneading, we should not be massaging unless you are a licensed massage therapist who specializes in oncology, because the pressure is different. We have to worry about lymphedema. There are all kinds of things that as fitness professionals and even massage therapists who aren't trained in oncology massage should not be doing. We should not be using foam rollers or what do you call them? Lacrosse balls or tennis balls for myofascial release in an area that is at risk for lymphedema, because that pressure to that area can restrict the flow of lymphatic fluid and increase the risk of lymphedema. So just kind of throwing that out there at you. Now I'm going to get back to writing slight anterior tilt here.
So are you saying we should see improvements with our patient within a couple weeks of training?
Yeah, I like to say that I think typically I like to do a 12-week reassessment, but bare minimum 8. And what that allows you to do is to reevaluate, you know, with what we have at our disposal, stretching, strengthening, balance, you know, flexibility, range of motion, whatever. Should we be doing something differently? Because if we're not seeing an improvement, what we're doing isn't working. So either A, the client isn't doing it, or B, maybe we try a different combination of things. And actually I'm going to throw in C, because their day-to-day habits could also be negating what they're doing. So for example, I can give you all these exercises to strengthen your glutes and stretch your hip flexors. But if you spend 12 hours at your computer a day and the amount of time you're sitting in that position completely outweighs how much exercise you're doing to correct it, then it's like anything else. It's a scale. You know, the more you put into it, the more you're going to get out of it. The client who's following their diet to a T and following their exercise program to a T is going to get better results than the person who works out once a week and, you know, maybe makes some modification to their diet. There'll still be improvements. It's just going to be much slower. All right, Kim says, and shake it out, Hannah, if you want to get a drink or something, go for it. Kim says she has 2 clients who have extremely tight hamstrings and pronounced anterior tilt. Been stubborn to turn this around, and they do sit at desks all day. Yeah, and Kim, I would be curious if there's something else contributing to the tight hamstrings, because usually tight hamstrings manifests in more of a flat back. So this is why, you know, a lot of times it's an anomaly, and we're like, I don't know why this is doing this. You know, it's a lot of push and pull to figure it out. Okay, so we looked at wing scapula from the back. We were, you know, looking to see if the hips were level, and then I turned you back around so that we could see if there was an anterior tilt. And I think we've already done all the lower body. So just to to go through this again, and you guys follow along with me. I have the right shoulder is slightly depressed, and also the right shoulder is more protracted than the left. And certainly, you know, if you're doing everything with this right arm, that makes perfect sense. You know, if that is the arm that you're writing with or you're typing with, that one is always going to be protracted. Left hip slightly medially rotated, which makes sense with the knee also being slightly medially rotated. And then we still see that right foot slightly turned out. Slight winged scapula. Once again, could be shadows, but we're just going to roll with it. I see it on the right side, and then a slight anterior tilt. All right, Kim, thanks for being here. Okay, we still have some minutes. So let's now, I'm going to have you once again, if you will, adjust your camera, and let's try and get as much of you in as possible. So I'm going to have you do a little squat test here. Okay, so we should be able to get most of you. So go ahead and stand, you know, like more or less shoulder width apart, normal stance. We're going to begin with your arms up overhead, but hang on a second. I don't want your arms to get tired. I want to tell you all what we're looking for. So the squat test also we're going to do from the front, we're going to do from the side, we're going to do from the back. And we're looking for much of the same things. What we're looking at from the arms is whether they fall. So whether they fall down. She's going to start with them up here. Do they drop? Do they bow out to the side? So we'll see that from the front. Also from the front, we will be able to see if her knees go inward, if her ankles roll inward. So let's focus on that. We may notice also if she bends forward at the waist from this view, it will be more obvious if we're doing it from the side, which we will. So whenever you're ready, Hannah, and we'll just have you do a couple nice and slow. You know, we're looking for stability versus wobbliness. Okay, so I see her start to bend forward a little bit at the waist, at the hips, at the midsection. A teeny bit of the knees going in, not a lot. And I don't see much of anything going on at the feet. All right, take a breather for a second, because I know it can get tiring holding your arms up. Does anybody see anything that I'm not noting? Okay, I'm assuming, Ann, you mean right foot? You're better than I am, because I can only see part of her foot. So yeah, right foot slightly turned out. Oh, there you go. Beautiful. There. I think now subconsciously you're like, I'm going to move my right foot out. Okay. Well, you see just a little bit of collapse in the knees, not a whole lot, but they're definitely drawing inward and bending at the waist. Okay. So pause for a second. Let's write this down. So slight, not knees, bends at waist and right foot out. All right, now let's turn all the way around, and you're getting a little exercise in now, see? So starting with your arms up, start folks looking at her ankles. We can see that right foot turned out. Let's see what her ankles are doing, what her knees are doing. Now I also see she's a bit askew. I think you just corrected that. The left knee looks to me like it's the least stable one. It's kind of shifts. Okay, relax for a second. Anybody else? Are you seeing anything unusual or different that you didn't see from the front? Way to right side more. Yeah, I couldn't figure it out, Kim. Like it looked like she was, when I said she's askew, that's probably what it is. She's putting more weight on her left side, which seems to, I mean, on her right side, more stability there. And that could also be indicative of a leg length discrepancy, compensating for a longer left leg, but this is pure guesswork for right now. Okay, so yeah, Stacy, left knee looks a little wobbly and shifts to the right. So I think we're all seeing the same thing. Pick a side, any side, Hannah, and we'll do it from the side. So again,
Andrea, I have to say goodbye, but I wanted to say one thing to Hannah. Don't listen to a word we're saying.
I'm trying to block it out.
You're perfect the way you are.
she is perfect. Oh, she's
Sorry,
so,
I have to go though. So
All right,
thank
all right.
you.
Watch the recording
I
later.
will. I will.
Okay, bye. Okay, yeah, I mean, we're picking, like, trust me, if usually my husband's the subject and he's like ready to divorce me for making him do this so much. He's a wreck and everybody's picking him apart to pieces. So, all right, let's give this a shot. We're almost done. Okay, so we see her fall forward at the waist. She doesn't maintain as much of an upright position. Definitely, I don't see any change in the arms. They might be dropping a little bit, but they're not bowing out. Okay, and then do you want to just spin around and let's do the other side? Okay, so let me hold on for a second, Hannah. When she goes into a squat, her upper body and her legs should be like this. They should be two kind of parallel lines. So watch what happens when this falls forward. See how it's not that perfect, like a Z anymore. Hopefully you guys see what I'm talking about. If not, I can draw here. Hold on. You can relax for a second. Let me draw a little. Actually, I'm a terrible drawer. I'm not going to even try. It's like, I'm trying to draw a stick figure. That's how far I got. I'm like, yeah, no, that's not working. But basically everything should be lined up. So when the upper body drops, it breaks those two parallel lines. And now we're getting almost perpendicular where one is about to intersect the other. I keep hearing little bleeps. I didn't know if that was messages. Okay, angle of calves should match. Thank you. That's a better way of putting it, Sheila. Angle of calves should match upper body. That's essentially what I was trying to say. Anne, can you explain ocular pelvic reflex? Because I'm not even familiar with that term. I don't know if you feel like unmuting or if you want to write it in the chat box.
Okay. So that has to do with your head position. So if you tilt your head up, your pelvis will shift with it. So it's
and I figured ocular was eyes. I just couldn't figure out how that went together.
So like pelvis.
So essentially where people are focusing on visually is going to change how their body presents in space.
As opposed to.
That makes sense. And usually I tell people to, and I wasn't paying attention to what you were looking at. We can do this again in a second. But usually I tell people, to keep their chin level, eyes straight ahead, and pick a focal point. And especially when you have people who aren't kinesthetically aware of their own body, it helps with balance for them to have that spot. So let's try and do just like you were doing, Hannah. Try not to change it. And let's see. Okay, she looks up. Or I don't know. That's what I saw at first. Her head tilted back. Now she's pretty level. So still falling forward a bit, but not terrible. Okay. So here's what we're going to do. Hannah, you can relax. You can pull your pants normal and all that stuff. We are going to have a little homework assignment. Okay. Let's just aim for the beginning of next week. So, give you a week. I will send out an email as soon as we're done. I'm going to send you the link to these new videos that I've done that we're adding to the course. I am going to reiterate these findings for Hannah, and all of us are going to put together an exercise program to correct any imbalances that we've found here. It can be yoga, it can be Pilates, it can be aquatics, it can be personal training, it's whatever. Now, this is only based on this postural assessment. We don't know anything about this client. This is all we're doing. So we're only talking about the balance of agonists and antagonists. So you're going to go to your module 3 And like I said, you'll see the section on postural assessments. It talks about janda and muscle balance and all this stuff. And then you'll see a chart. It'll look, almost like a calendar, as far as the chart goes. And it will say forward head, rounded shoulders, elevated hip. And it's going to say probable tight muscles, probable weak muscles. Then you can think based on that what exercises you could do, or you can super take the easy way out and go to the next couple pages, which will actually give you exercises to correct those imbalances. Okay, but you're still going to have to do a little bit of work here. And so we're going to take these 1, 2, 3, 4, 5, 6, 7-ish imbalances. And Hannah, we are really reaching, because honestly, if you didn't change a thing, you're really going to be fine. But we're going to take these 7 muscle imbalances and we are going to address those. Don't worry about her cardiorespiratory fitness. Don't worry about her balance or any of that. All we're focusing on are correcting these 7 muscle imbalances. And then, so I will send you all an email. And then if you will simply return your response to me in an email. It can be bullet points. Doesn't have to be fancy. I don't care if you cut and paste a picture from Google Images of an exercise that you want to use. But let's just address each of these. And this is kind of the, let's call it the, hands-on practical component of your testing. So I'm not going to grade it, not A to E, but I will say, okay, what about this? How could we have done this differently? So I will let you know that either I think you did a perfect job or you did a real good job, but let's talk about this a little bit more. So if you didn't hit it, nail on the head, then I'll work with you through it so that you understand, or maybe you teach me something that I'm not aware of, which, we can all always learn. So before we go, aside from a big thank you to Hannah, also in the email, you tell me black, white, short sleeve, long sleeve, and what size. Women's shirts will shrink and the long sleeves are unisex and they run big. So keep that in mind. She is beautiful and we are trying, this is from Stacy, we are trying to find something. You can look back, actually, it's funny. I will also find the recording of the assessment that I did on my husband, because it'll probably be good for you all to learn for, and we will learn from, and we do the whole thing. Like we do the postural assessment, the Trendelenburg test, the Thomas test, all that. So I'll share that video with you. I'm going to send you this important email, and then let's just make a goal for next Monday, Tuesday. I mean, I'm not going to fail you if you don't get it to me on time, but I know we're moving into the holidays and everybody's going to get real busy. So let's try to get it done earlier in the week. Next Wednesday, same time, 10 Pacific, we will do the goniometers. So I will either have my daughter or my husband, I'll have somebody there that I can actually physically do. And yes, I'm going to teach you how to do it virtually, but I'm also going to teach you how to do it in real life in person. So I need to have somebody there to do it with. 12-inch goniometer is what you want to use more often than not when you're in real life, but the little bitty 4 to 6-inch one will work beautifully right up against your computer screen. And, if you can't make it, I know I'm not going to be able to appeal to everybody as far as timing, then of course it'll be recorded. So any questions, concerns, comments, confusions?
Well, I just want to say thank you for your sweet comments. I really appreciate that. And it's so funny being, the model, it's, you don't really think about, what's different on your body. You're just paying attention to your patients and your clients. And so some of the things you guys were saying, I'm thinking, you know what, that is tight, or I do have, pain here. And so it'll be helpful as I move forward in my life.
You got some advice and a shirt.
Yeah, bingo.
And we'll have more opportunities for shirts and all kinds of goodies. Also, just if you want to check it out, and this is, I'm sure, way premature, but just for kicks and giggles, one of our former students created a website called exercisebrochure.com, and she's created business cards, brochures, and rack cards that you can change your name and phone number and put your own logo. I really don't think they're expensive at all. I have nothing to do with it. You just order it straight through there. But you can also get on ideas, even if you want to do it yourself and create the document. Look at the verbiage, because she's basically taken the best of everything that we've put together, you know, and put it into a sales piece, so to speak, that could be handed out at doctor's offices. So just something to think about. Okay, well, thank you all for being here. Remember, we are not going to meet Thursday. I will be meeting with you on Wednesday. So I think you have 2 more meetings with Dan Ritchie this week. And any questions, just go ahead and write me. And before I forget, in my midlife brain fog, I am going to hang up and send you an email.
Andrea, you said look at module 3. Where do you find that?
Okay, so, and if you need to go, go. Otherwise, let me explain this. So when you are on ceti.teachable.com, and I know this is a bit confusing. So, you know, you have your recorded videos, and then you have your cancer exercise specialist and breast cancer recovery BOSU specialist in Teachable. You have a separate access for FAI. So you're going to click on the Cancer Exercise Specialist Advanced Qualification course, and the whole curriculum will come up. Module 1, Module 2, Module 3, Module 4. Now, I know, Sally, you just ordered your books, so you'll have the hard copies in the next, you know, week or 2. But you can download those modules. So the first thing in each module is the handbook. And it gives you the option to actually download it. You can download it, you can print it. If you do want to order the books, it's about 2 weeks, because since I'm in the process of redoing everything and changing up the curriculum, I stopped printing this book a while back. So now I'm printing on demand, which is why it takes 2 weeks.
So Andrea, you went a little fast there. So you said go to CETI Teachable.
Yes. Let me see, again, if anybody has to go, no worries. I am going to try and go to the website so I can show you. Hold on a second. And I'm not good at this, so bear with me. I might disconnect us for all I know. Okay, let's try that. Now you get to see all my emails. Here's the new book I'm working on. You get to see everything that I have loaded on my computer. All right, this isn't working real well. Do I still have you guys? Yes?
Yep.
Okay. All right, here we go. So let's go to ceti.teachable. All right, can everybody see my screen? Yeah. All right, so you're gonna, of course, log in, and then you'll go to My Courses. And so, of course, my cart looks different than yours, but this is what you're looking for: Cancer Exercise Specialist Advanced Qualification. You're gonna click on that. And then again, this is gonna look different, Sally, when you go to yours, because you're gonna be in the back end. But see here, Module 1 Handbook,
Right.
Module 2 Handbook. You'll simply click on that. And now it's giving me the definition of a handbook. Awesome. Obviously that clicking doesn't work from where I'm at, but oh no, it did. Look, and see, here's the handbook. There's my daddy. All right. And you can from here download this entire handbook.
So when I tried to get in there once before, it was asking me for a password.
Yes, we did not set you up a password, so you shouldn't need one, but Greg or I can walk you through that also. And if anybody else has a problem, reach out. So look, I'm showing you Module 3 right now. Okay, so this is where we're at. Let me just scroll through here. So here's your session, or your section on muscle imbalances, posture. All right, and you scroll. There's a lot of review of anatomy and physiology. You don't need to memorize all this. There will be some questions on the test for sure, because we need to know this stuff. But then here we go into our postural assessment. Tells you exactly what you are looking for from each direction. Shows you the balance test, the modified Thomas test here, okay? The squat assessment, And then here, if you look, these are the compensations. So for example, as we are looking to do Hannah's exercise program, we look and see, okay, here we go, foot turns out. Here are the tight muscles. Here are the weak muscles. So particularly on that right side, we're going to be stretching the soleus, the gastroc, the tensor fasciae lata, and then we are going to be strengthening, and sometimes you're strengthening and stretching. Then, we can look excessive forward lean. Notice we see the same things, tight soleus, tight gastroc, tight hip flexors. So we're seeing some common denominators. So this is just for the squat test. But then we go on even further. Dun, 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 and now we've got this whole chart of postural deviations. So we look here, let's see, shoulder protraction, right shoulder, tight pec, major and minor, tight lat. And then weaker, I'm going to say weaker, rhomboids and middle to lower traps. So, okay, great. What does that mean to you? Well, now you can take that a couple pages further, and here we go, correcting round shoulder syndrome. You've got samples of the exercises. So you don't even need to figure out which exercises to do. You go, okay, my goal is to stretch the pecs and lats. Here's a plethora of exercises that we can do. Or you say, oh, I can do this in yoga, and that's a half moon pose. And it does the same thing. So does that make more sense, Sally and everybody, as far
As long
as?
as I can get in there, it'll be fun.
Okay, we'll get you in. So you either write Greg or I, and we'll get you in. I think what you're doing is you keep creating new accounts, which is the issue. So before you waste a bunch of time, just call Greg or I or text. Okay, so hopefully that is helpful to you guys, and you'll see it just keeps going. Lots of exercise ideas. As soon as I am done with the new materials, which will be by the end of the year, I will share that document with you. You're right on the cusp of the last edition, which was done 2 years ago, and the current edition. So you will actually be able to use the new content for, if you decide to remain with us, to retest in 2 years. So hopefully that all makes sense. I don't want to flood you with too much information, but.
That's great. Okay, I have to go. Thank you
All right.
very much. I appreciate it.
Yes, of course. Okay, guys. Well,
Bye.
have a
Thank you,
wonderful
Hannah.
rest of the week. Thank you,
Thank
Hannah,
you.
so much.
You're
Bye.
welcome. Bye, everyone.
Okay, bye-bye.